Hello everyone, and welcome to the webinar, Montana Healthcare Foundation webinar number 2, Financing Integrated Behavioral Health. My name is Libby Ethier, and I am a project assistant at the National Council for Behavioral Health, and I will serve as your moderator today. Before we begin, I'd like to draw to your attention some important webinar logistics. Today's webinar is being recorded, and you are currently in listen-only mode. If you are listening on your phone, please enter on your telephone keypad the audio PIN number from the control panel on the right of your screen. You may send us any questions throughout the webinar. Simply type your question into the dialog box on the right of your screen and send it to the organizer. Depending on the question, we may type an answer back to you, interrupt the speaker to ask, or save it for the end. We will answer as many questions as time allows. An audio version of the entire webinar and a PDF of the presentation will be emailed to you by the end of the week. Following the webinar, we invite you to complete a short survey. If at any point during the webinar you experience technical difficulties, please call Citrix Tech Support at 888-259-8414. At this point, I'll turn it over to Joan King.
Hi, good afternoon, everyone, and thank you for joining us this afternoon for part 2 of our three-part series on financing. And we're happy to have Virna with us. Just wanted to frame this a little bit to say I hope most of you were on part 1 2 weeks ago. We got lots of great questions, and Virna has incorporated those into this presentation, and hopefully we're also going to have time to do some questions and answers today, and if not, we're going to follow up with a time to be able to do that. So with that, I'm just very grateful that Virna was able to join us today and share more of her incredible expertise in sustainability, financing, and basically practice management. So Virna, I'll turn it over to you.
Great. Thank you, Joan. Thank you, Libby. Great kickoff. So I want to thank everyone for joining today. And what I'm really hoping to do today is a deep dive, as you can see from our title slide here. And what I really encourage you to do is to ask questions as we go through. I'm watching the chat box as we go along. So I'll really try to incorporate your questions in as we go along, or stop and answer them, during the presentation, so that we can make sure that we get all of the information out to you that you need. I really want to thank everyone for sending questions and comments and thoughts, because I really try to bring some of those things into this webinar. And again, figuring some of this out and creating your sustainability plans and doing these pieces is really, it's one of those things that's a marathon and not a sprint. So you're going to be working at it for a little bit, but we really want to try to make sure that we get you off to a start and answer any questions that you have as you go forward. So I have a slide up on the screen that's important to our funders, so I want to have you just take a minute to review the information on this slide. Thank you. So just going back and thinking about what we talked a little bit about last time, we talked about the front end, our clinical operations. We talked about the back end, our billing and our contracting. We talked about knowing what our costs are and really looking at those. We talked about our expenses and really knowing what our expenses are. We talked about billing and coding, and we're going to talk about some of those things a little bit more, and we got some great questions. We got some questions on contracting, and then a little bit more on a dashboard and putting a dashboard together. So again, feel free to put in any questions, but these are some of the things that we talked about, and again, that we're going to try to revisit. So what are we really going to try to do today? We're going to try to answer questions that are very specific to your organization and sustainability. And so, bear in mind that you're going to have some similarities across the board, but, a hospital-based clinic is different than an FQHC, is different than, a physician office, is different than, a community-based organization with a satellite clinic. And so we really want to give people information that's specific to where they are, the populations they see, their payer mixes, the type of people that they have. So, you know, all of those things are going to play into your creation of your sustainability plan. So if you have specific questions that are specific to your organization, then please don't hesitate to ask them. We want to try to provide more detailed information on developing your plan, right? So again, really doing that deep dive. What do you need to know? How much revenue? What is it going to look like? And trying to pull together all of the details you're going to need to really create that plan. And then most important, I really wanted to make sure that we responded to the feedback and the requests from the last webinar. And again, I appreciate them. And if people, you know, come up with burning questions after this webinar, you know, we're all going to be here to support you and continue to answer the questions that you have. So one of the questions that I got that we didn't spend a lot of time talking about last time, but I wanted to bring up this time. This always comes up whenever you talk about sustainability and integrated care, is the idea of warm handoffs and whether or not you can bill or not bill. And the answer to that is sometimes, sometimes not. And it really depends on a lot of things. So thinking about your workflows, we talked a lot about how your workflows might change based on your sustainability plans. And here's an example of that. So we have many times centers that will have somebody doing warm handoffs, and they maybe can see that patient or maybe not. So if I were in my office and I got a phone call from one of the primary care providers and they asked me to come and do a warm handoff and I was with a patient, maybe I would get up and go meet that patient and set a time for them to come back. But is there a process for me to look and see if one of my behavioral health coworkers is maybe not seeing a patient right now, and I might be able to introduce them and have them see that patient? So really trying to optimize the warm handoffs in terms of who does them is an example of when your workflow might change, and then the potential to bill for that visit and allow somebody to have a full behavioral health visit might allow for a bill to be dropped on that particular day. So many times organizations will say, well, you know, I'm not able to bill for same-day visits in my setting, and many times and in many states and many settings, particularly for Medicaid, you're not able to bill for same-day visits, and that is certainly a problem for many of us. However, there are times when you are able to bill. So third-party payers, so people who have private insurance as an example. We had a clinic recently that had a lot of TRICARE and saw a lot of military families and veterans, you know, to be able to bill for those same-day visits. Medicare, you can bill for a same-day visit on Medicare as long as it's a different diagnosis. And so really thinking about what that looks like. So do you need to train staff to say, okay, this is a certain kind of payer, my workflow is a little bit different for this visit? Most of the time what I encourage places to do is document what you do, code what you do, and on the back end look to see whether or not that's something that could be billed for. And you should always code what you do. So it's always important to try to have a warm handoff, you know, meet the requirements of a billable encounter if you're able to do that. If you're not, then that doesn't always mean that you're not going to get revenue, because many times us being able to meet that patient means and set a small goal means that they're going to come back and keep that initial visit. And also thinking about who does your warm handoff. So sometimes organizations will say to me, you know what, I have this really great care navigator or community health worker or MSW student, and they're in my practice a couple of days a week, or they're in my center. Is that somebody who can do a warm handoff? The answer is yes. But do you want to think about a process that has them do it unless there's someone available and it could be a billable visit? So I think you need to think about how you have a workflow for warm handoffs and how you can try to optimize them. And it's definitely something that takes a little bit of practice. But again, I always tell people, you know, generally if you're not with someone else and you see someone and you have a visit and you provide an intervention. So if I see someone for a warm handoff and they were referred to me because they're been feeling very anxious, and maybe they scored positive on the GAD and the screening. And then I talk to them, and I talk to them about a goal, and I set a goal with them. And I do some behavioral activation around goal setting for the next couple of days. And then I talk to them about their symptoms and a little bit, maybe they're having difficulty sleeping and some other symptoms maybe from the GAD. And then I talk about a plan to see them again and a plan to reduce the GAD. Then that really meets the requirements of a billable visit. I have a mental health diagnosis. I provided an evidence-based intervention around behavioral activation, or sometimes in warm handoffs, it's motivational interviewing. I assessed and reviewed symptoms with patients, and then I have a plan. So oftentimes I think we tend to overthink what's required in terms of a billable visit. As long as we have those pieces in place, that's a legitimate, behavioral health visit. But certainly thinking about who else in your system can perform them, when they're billable, and really putting that process in place. What payers can I get paid for a warm handoff or visits on the same day, and really trying to then back into your workflows. Thinking about behavioral health codes and optimizing. So one of the questions that came up was around some of the codes, and we're going to talk about them. But I really wanted to remind folks, this is actually from the regs and talks about the services that social workers are meant to provide, and that they are really limited to the diagnosis and treatment of a mental illness. And so you may ask a little bit about why we're showing you this slide, and that's because many of you asked about the health and behavior intervention codes, or the 96150 to 96153, which is the group series. And many times organizations think about using these codes for behavioral health services. And so there's a couple of pieces. One is that CMS has been very clear that these codes do not apply to social workers, and that unless your state, which your state does not, as far as I was able to determine the other day, carve them out, then these are codes that social workers should not be doing. And predominantly in integrated settings, we have social workers. So the ones who can use these codes are psychologists. So as an example, if we were going to run a group around health behaviors and use the 96153 code, then a psychologist could actually run that group and bill for this code, but a social worker could not. And so many times organizations were using these as sort of a 15-minute, there's a 15-minute time frame attached to these codes for warm handoffs. And so that's not something that you could use. Or many times organizations doing integrated care, providers might refer patients with diabetes who needed some behavioral counseling around their diabetes, and organizations would refer to the behavioral health providers. And that's not, one is these are not threshold visits, or you don't get paid very much for these visits. Generally it's around $50. So you would want your behavioral health providers really working to what was in their scope and their licensure, which is the treatment of a behavioral health diagnosis, and using a medical diagnosis would actually be out of their scope. And these HBAI codes are really around a medical diagnosis, and depression is actually carved out of them. So thank you for those who asked, and be glad to answer any questions. The other codes that came up are the prevention codes. These are also not codes where you would get as large of a reimbursement. And these codes, again, are sort of out of scope for the social workers. These codes are really meant for, in addition to, for a primary care provider using it in addition, such as obesity counseling, or they've been used around HIV testing, and some of those services. They are not really designed for behavioral health providers to use, and they're often attached to, again, a physical health or medical diagnosis, which is not in scope for the behavioral health providers. And so these are some things to think about. And if you think about what the time frames are, so if you look at the HBAI codes and you think about a 15-minute visit attached and what the reimbursement is, it doesn't actually make sense to use these over behavioral health codes such as a 90832 where you would get a full visit reimbursement. The provider would be working in scope and you could, provide the behavioral health services that way. So again, just some information, these codes did come up. And in fact, we've had to work, I know Joan and Jeff, who are my partners in crime here from the National Council, have had to work with a lot of organizations who built some of their integrated models around some of these codes and really try to change that system. So just to provide some information, and we can certainly provide more information. And so also talking has come up a little bit, this F54 code. This is a code that is no mental health diagnoses, but psychological factors affecting physical conditions. So people are using this code around the country. People asked me, well, what might we use if there is no mental health diagnosis? So I would say that if you're getting referrals for patients who have diabetes, as an example, and don't have a mental health diagnosis, then those are not patients that you would really want to see predominantly as a behavioral health service. However, there are times when maybe you would get a referral, and where this comes up maybe is around prenatal assessments, where someone, you're doing a prenatal assessment and someone doesn't have a mental health diagnosis. And so here's some information sort of what could get included or excluded, and certainly we can send you more. But this is a code that you can use periodically if you were asked to see someone. Maybe a provider said this patient was, very upset. They maybe just got a new medical diagnosis, and when you assessed them or spoke to them, there really wasn't anything other than this code. So it's not a code that I would use often, but you certainly know it's there, and I wanted to give you that information. So we talked a little bit last time about how to do some of the salary, and people asked me for sort of just, some data points that you could think about as you're doing this. So I just put some data points and a little bit of information in here that you could look at. So if you're paying a staff person, $50,000 and change, and then you're adding fringe, which is your benefits, and your overhead, which is, keeping the lights on and management, and that total comes to $75,000. And your average reimbursement for a visit is $100. So when we think about your average reimbursement, we want to make sure that you're taking reimbursement from all of your payers. So sometimes people will say, well, that doesn't include my uninsured. And if you have a lot of uninsured patients, you want to make sure you count any revenue from self-pay, but for most of us that tends to not be a lot of money. But if I see a lot of uninsured patients, then my average reimbursement is going to be lower. So I want to make sure that I include those in. And for the FQHCs on the line, you do get some funds, the 330 money, for caring for people who are uninsured and underinsured. And you want to think about what percentage of funds would go into calculating your reimbursement for your behavioral health visits. Maybe you distribute it out by the number of visits or percentage of visits, however you do it. But you want to make sure that you include that information into your average reimbursement for your visit, right? And so when we think about what some of the requirements are, I know we have a couple of FQHCs on the line, so I put what HRSA sort of thinks is the average or recommended visit for a full-time social worker, which is 1,550 visits a year. So if you're thinking about what your work week is, generally 44 weeks a year, because we have sick days, we have vacation days, so generally 44 work weeks in a year. Sometimes organizations use 48. So when you think about what that boils down to, it boils down to about 3.5 patients a day. And so you might think, well, you know, that's pretty easy, right? But then how does that change if you're only collecting 80% of what you're actually billing out, right? Or what if some of those visits are same-day visits and you're not billing them out at all? So you want to make sure that you're looking at those bottom data points, right? To try to make sure that you're accurate in figuring out your productivity or how many patients you would need a day to be self-sustaining. So maybe it is 3.5 patients a day. However, if I'm only collecting 80% and I see maybe 2 visits a day that we can't bill out because they're same-day visits, then that's going to change that number of patients or visits a day that we have to be self-sustaining. So this is just talking a little bit through what data points you need to have so that you can know what you need to do or need to think about in order to put together your sustainability plan, right? So thinking about your billable visits, right? So how many a day and what does that include? So when you think about how many visits someone has to have, they're going to have maybe crisis visits, they're going to have warm handoffs, they're going to be doing initial assessments and treatment plans in groups. So thinking about what that looks like. We talked about productivity or what a clinician does every day being a painting, and productivity is one color in the painting. So at the end of the day, it's really helpful to know how many billable visits somebody has to have on a given day in order to be self-sustaining, and then be able to paint around that what all of the other services that they might be doing that are non-billable and what percentage of their day that winds up to be, so that you can see where you stand, right? So how many warm handoffs on an average? What does that look like, right? And then if you think about 80% capacity, which means 80% time sort of in those direct services, it really lets you see that a little over an hour a day is actually meant to have capacity to do other tasks. Those are your phone calls, your follow-up, your coordination, your conference with your primary care providers. And so when you start to put all of these pieces together, you can start to paint the picture. So I was talking today in my management team, and we were talking about staff that were over 80% capacity and over 100% productivity. And those are staff who are really busy folks because they're seeing a lot of patients, spending a lot of time in direct care, you know, certainly over their productivity. Does that mean all of those services are billable? No. It means that they're seeing a lot of patients. It looks at their capacity, which means that they're spending most of their time in those direct services and they don't have a lot of time to do other activities like they really need to. But in terms of sustainability, somebody could have very high productivity and do a lot of warm handoffs maybe, or a lot of same-day visits, or patients that we're not able to bill for some reason, and they wouldn't be sustainable even though they were at their productivity numbers. And so it's really important to look at the entire picture of all of the services and what the reimbursement is across the board. And then you can really start to paint the whole picture. So when we talk about what's happening on the front end, what am I doing? How much time am I spent in care? How many patients am I seeing? And taking that information and combining it with your back end, what percentage of visits am I getting reimbursed for? How many of these are billable? What does this look like? And taking all of those data points and putting it together from your front end and your back end to really paint a picture of what your sustainability plan needs to look like. And I know this is sort of not easy to see, and a question from the audience around the licensed counselors, so they cannot use those codes. It actually follows the same. The ones that can use the HBAI codes are the psychologists. So what came up also were the screening codes, and people asked questions around the screening codes. So I put them out here again. You know, one of the things about working in integrated settings is that you're not just reactive, right, and sort of waiting for for primary care to send patients, that you're being very proactive and you're really being a part of the primary care team. And that means doing things like, anticipatory guidance and maybe seeing patients before primary care visits, or having new moms come back in and doing things like ages and stages questionnaires. So here's some screening codes that I think are helpful, and folks are actually getting some reimbursement for these, which is always really helpful. So the 96127 is for your PHQ 9s and 2s. Those are always fun to have and to look at. And so certainly I would think about using these each time. What you want to make sure is that you're not using them as your primary code. You want to make sure that if I'm doing a PHQ 9, every time I see a patient with depression, that maybe my 90832 is first and then my 96127 is a secondary code, so that you make sure that it gets dropped as a secondary code. So are we all going to be able to fund our integrated care off of these codes? Absolutely not. However, they range anywhere from a couple of dollars up to $10 a visit, sort of depending on your payers. Also, some of them only will pay for a certain number of, tools. So it's helpful to know for your payers, but certainly it does help you with tracking, and it allow you to bring in some additional dollars. So one of the things that is helpful to know also is that the ages and stages questionnaire, which many of you use for peds, there's some tools for autism, some of the behavior assessment scale for children. All of those are actually covered under the 96127, the Connors if you're doing any care for ADD, and some of those things. Under the 96110 is more of the, and also for those of you doing the pediatric symptom checklist, that actually falls under 96127 as well. So the 96110 are your MCHATs, which are for your autism, the Vanderbilt, some of the others. So there is a complete list that we can send out to folks if you want it. But these are codes that support some of the tools that you do in integrated primary care that might be helpful, again, not just for tracking. So one of the things that I do in my system is that any child who has a diagnosis for attention deficit should also have one of these codes that we did the Vanderbilt or the Connors, right? And they should have it, every couple of months. And so it helps you with tracking as well as it could help you with your sustainability. And thinking about substance abuse. So there are codes for substance abuse around substance abuse screening and substance abuse referral for services. These are tracking codes. These are H codes. You're probably not going to get paid for them for the most part, although there are a couple of payers that will, but they will certainly help you with your screening. So again, using these codes actually help you paint the picture for what your staff is doing, as well as help you bring in some additional revenue. So it was talked a lot about SBIRT and people doing SBIRT. So again, your screening. So the thing about SBIRT, and people have asked about the SBIRT codes, and the thing about the SBIRT codes is that they don't actually make a lot of sense. And that is because they are attached to a 15-minute time frame. And so when we think about what SBIRT is, it's screening for substance abuse, it's a brief intervention, it's a referral for treatment, which are things that all of us probably do fairly routinely. And so using the SBIRT codes means that whether you're a behavioral health provider or a primary care provider, you're using 15 minutes of your time to use that SBIRT code in which you're only doing these SBIRT services or the services related to the SBIRT visit and code. And so it's hard to do that sometimes, a 15-minute visit, particularly if you're a primary care provider. And then if you think about if I'm a primary care or a behavioral health provider, my spending 15 minutes just talking about the expert services and using the expert codes, if I'm a primary and getting a low reimbursement because it's not a threshold visit, I would be better if I'm a primary care provider to use an E&M code and get paid my regular visit rate. And the same for behavioral health, where you would, see the patient as a behavioral health visit, of which part of it could be referring someone, providing a brief intervention. Maybe you're doing motivational interviewing, and you're doing some things like that. So you want to make sure that you're meeting the requirements for a billable behavioral health visit. But it doesn't always make sense to use the expert codes, even if you're able to use them with some payers or in your setting, but to really think about whether that makes sense sort of from a workflow and reimbursement perspective. So I would encourage you to really think about that as you go forward. And certainly what really matters is that you're capturing the spirit of expert, which is that you're maybe using the screening code so that you can track how many times you screen people, or you can track how many times you did a DAS, an audit, or a CAGE in your system. You can track your brief interventions, right? So how many times was substance abuse a reason for visit or on a visit diagnosis, as an example. A referral, how many times did you put a consult in for primary care, put a consult in for substance abuse services, or to behavioral health for substance abuse follow-up, or, how can you track them both internally and externally, right? If I'm a behavioral health provider, do I put something in the system referring somebody to an outside substance abuse program or an internal microgroup, right? And then really being able to track that. So that's something, if we have a medication assisted treatment program and we screen someone, we identify them, we refer them to our program, and then we start to care for them, we want to know, we want to be able to report that, but we don't necessarily always use the expert code. So I encourage you to really think about that as you go forward and whether or not that makes sense entirely. So thinking about crisis, we talked about this a little bit. So the 90839 code, we mentioned it, very briefly last time. A couple people had some questions about it. One of the things is that, really 60 minutes is not a visit length that you should be using pretty routinely in an integrated setting. In fact, I would say that you should not be using them in an integrated setting. And so thinking about if someone has a crisis, as opposed to using a 60-minute therapy code, that you're then using this crisis code, it helps you track how many times you're seeing patients that are in crisis, particularly in a time when we're trying to document and keep people out of the hospital. If you run a report and you say, wow, we did 10 crisis visits this month, those are 10 people that might have wound up in the emergency room if we hadn't intervened and provided some behavioral health crisis services. The other thing is that many times the 60-minute therapy visit needs an authorization, and this does not need an authorization for most of your payers, so that's also helpful. And again, paints the picture about what your staff are doing and helps you with value-based payment, because then you're able to say, hey, these are the people that we kept out of the emergency room. These are the people that, we helped here in the center, and maybe we prevented an admission. So there's certainly sometimes when you're able to use that to negotiate. So it's really helpful to be able to report. The thing is that you really should have training with staff to make sure that they're meeting the criteria for a crisis visit, that someone is in acute psychiatric crisis that requires intervention, someone is acutely and imminently at risk to themselves or someone else, having, very acute psychotic symptoms or psychosis, as an example of when you might use a crisis code instead of some of the others. But it's certainly a helpful code to be able to do. So one of the things that we have learned, from doing this work is that the largest impact we've been able to have on direct revenue, which, is what I sort of say are dollars in the door. That's our favorite kind of revenue, right? The actual dollars in the door. The largest transitions that we've often been able to make with organizations is around scheduling. And I say that because scheduling optimization and revenue is so closely tied, obviously because the number of patients that you see is directly tied to your revenue. And so your ability to really optimize your schedule, we had practices that we worked with, and one in Montana that I remember particularly, who was part of a sustainability project, who was able to dramatically change their revenue by doing no other activity than optimizing their schedule and really looking at where the gaps were in their schedules. And so if I look at what the schedules are today, maybe they're full, but if I look at yesterday's schedule, how many open slots did we have? So a full schedule, a lot of times people say, well, my schedules are full. Schedules being full does not translate into full patient care schedules. And so what does it really look like going backwards? So how do we make sure that we're optimizing and we have the least amount of open slots? So being able, can't treat a seat kind of theory, to making sure that you're really providing access to your patients. And even doing some very simple things like training your front desk or the folks answering your phone. If I'm calling and I'm canceling an appointment with Joan for this afternoon, then that front desk person often says, okay, Virna, well, thanks for calling. I'll see you next Monday at 4:30. Instead of saying, well, Joan has an opening tomorrow at 2 and an opening, she just had a cancellation for Thursday at 4. Which one of those appointments would you like? And so really making sure that people are responsible for filling those slots. And also not scheduling out by your clinicians. So many times clinicians will say, Joan, I'm really glad to start working with you. Monday at 4:30 is your slot. And they might schedule Joan out for 10 weeks at a time. And what happens is, many times, unfortunately, we know that we're not always successful at engaging people into care. And so by scheduling out, often we wind up with slots that aren't full. So not scheduling out so far, because often Joan doesn't get taken out of the schedule, and that fills up a slot. And then not incorporating some form of open access, whether it's around med management, whether it's around people who are missing 50% of their appointments, or however you decide to work in open access. Almost always by incorporating some form of open access, you're able to really increase the number of patients. And, again, I don't really work with clinicians around productivity. I think we're talking about productivity and actual number of patients because we're sort of very specifically talking about a productivity or sustainability activity. But really, at the end of the day, what you're working with your clinicians around is increasing access. So I never really talk about the P word. I talk about access and really looking to saying, we have in our center here 2 behavioral health providers, and at the end of last month, between 2 providers, we had 31 slots when treatment could have happened and it didn't. And I'm just wondering, because we have so many people that need to see us and who need care in our community, that was 31 times that someone could have got treatment and didn't. How do you think we can fix that? And here's some ways that other clinicians have fixed that. They have been a shadow schedule. They've talked about patients who haven't kept appointments in supervision to talk about stepping people down into open access or into biweekly. There have been, things like engagement sessions and other kinds of activities that have been put in place around scheduling optimization. And so again, I really encourage you, you know, if you go into your schedules and you go back and you do, we're in March, and so if you look at the month of February and you count all of the times in your behavioral health schedules that treatment could have happened and didn't, that will, and you multiply that by your average reimbursement, that will give you a sense of the kind of revenue that's often attached to scheduling. So just, you know, something to think about. But again, one of the largest things that we often do is scheduling optimization around sustainability, and really making sure that you're listening to the story that your patients are telling you. And, you know, often what happens when we have full schedules, we schedule intakes out, you know, 2 weeks, 3 weeks, 4 weeks, and every day that goes by, there's a greater percentage that that patient won't keep that appointment, and those are often longer slots. So transitioning to same day, next day, changing intake appointments to 30 minutes as an engagement session. Patients who are not keeping second appointments. So if you look and you see that a majority of the patients missing appointments are second appointments, then maybe changing your intake process and doing some kinds of engagement activities. Thinking about length of treatment, right? What is your average length of treatment? When we think about things to know on the business side for behavioral health services, how long are patients in care? You know, is it an average of 4 weeks, 12 weeks? So too long is a problem and too short is a problem. Many times what we see is that patients sort of drop off after episodic treatment, you know, 5 or 6 sessions, and they come just enough to keep their slot. And so how do we address that on the treatment side, and how do we try to design schedules that accommodate them and meet their needs, and then also allow us to have access to other patients? And so really thinking about what schedules look like, really thinking about what you need to do to be able to optimize them. And one of the places to start is to really define what a no-show or a cancellation is. Not that it matters, because an open slot is an open slot, but it helps to be on the same page. So are your patients not keeping appointments? And why is that? Is it they're scheduled too far out, or what are some of the issues versus canceling, which is often I'm trying to hold my slot, or I don't have transportation. And in either case, maybe open access is something that would work for those patients. So really doing a deep dive into what your patients are telling you around those open slots. So how many open slots do you have, and who are those open slots? What visit? First, second, how many visits? And then really trying to come up with some solutions is a huge part of your sustainability plan and can really affect your revenue. So we've talked a real lot about the payer mix and knowing who pays you. This is so important. If you haven't had a chance to do it, I really suggest that you go and sit down and really find out everybody that pays you money, everybody that you can bill for, everybody that you have a contract with, so that you can really have it all in one place and really look at them one by one and see what you need to address for each individual payer. Do we have people credentialed? Do we have all the codes that we need? Are they paying us what they're supposed to pay us? Are there things that we need to add to the contract? You know, what does this really look like? Are there things that do they pay us for same-day visits, or do they not? What are some of the rules? What other codes do they use? Are they going to pay us for screening and some of the other things? So really knowing who they are and really knowing what they pay for. So medication-assisted treatment, as an example, some folks asked about that. And also knowing why they deny claims, right? So it's really important when you think about sustainability, if you're billing for behavioral health services now, to really look at any denials. And sometimes people say, well, denials aren't really a problem. You know, we only have a couple. Well, a couple, first of all, you don't want a couple, right? You want to try to figure out why you're getting denials. And also, as you grow your services, a couple winds up to be a couple more, which is a couple more and a couple more, and that can really add up. So it's always important to do, every once in a while, I will periodically pick a particular month and I will do a root cause analysis for every single denial that my department gets for a behavioral health claim. And while that might seem a little bit extreme, we have actually learned a lot from that and found out that there were things that kind of slid under the radar that we could have fixed, and really helps us drill down to some problems. So, you know, something like that is really helpful, even if you wanted to just take the last month or the months of January and February and look at all your behavioral health denials. You might find some that, you know, are because somebody put substance abuse or obesity as the primary diagnosis. Maybe it's a code that somebody was using. Sometimes it's about a provider being credentialed, and then you can go back to them and say, well, wait a minute, can you pay this as a non-participating claim? You know, is there a provider that we can use to support this claim? So really looking at some of those pieces, and it's so important to know your payers and to maybe make that grid that we talked about last time. So when we think about data points and going back and really figuring out your sustainability plans, right? Where are you getting your denials? What are your average amount of denials, right? So I know we're never going to get paid 100%, but I have an idea what my denials look like, and I know whether they go up or down. I look at them pretty frequently. What percentage, right? So we want to at least collect for 90% or better. So if we drop 100 behavioral health claims, we want to at least get paid for 90 of them. You know, ones that are billable that we're dropping out. And that's really going to help us figure out our average reimbursement. We talked about this sort of quite a bit from the beginning. Look at all your payers, including your uninsured. If you don't count your uninsured there, then it's not a true reflection of your average reimbursement. Think about open encounters. So open encounters for me is actually one of the data points that I look at very closely. And that's for a couple of reasons. I get reports of open encounters, and I get it every couple of days. And I like to look at it because it tells me some things that are really helpful. One is it tells me who is or is not practicing concurrent documentation, which is a best practice, but also, you know, sort of tied to efficiency and patient satisfaction, and certainly we can help folks with that if you need help. The other is that many times if providers have open encounters, it tells me that they're struggling in some way if there's a lot of open encounters. So if they're struggling with time management, with patient volume, with the electronic health record, it's like a red flag. And so I know this is not going to be a popular analogy, but I refer to it as a management roach, which means that that's the one glaring problem that I'm seeing, sort of the one big roach, but that there's probably lots of other things that they're struggling with in their practice, and that helps me identify people that are struggling. So I like to look at open encounters. It's also very closely tied to revenue, which is why I put it here. Because if you have encounters that are not being closed on time, then many times organizations are losing encounters or sustainability for timely filing. And it's also a quality issue. So that's why I put it on here. Thinking about open slots are, again, we talked about them quite a bit. And I had a question here about talking about shadow scheduling. Again, so one of the things we were just talking about, giving clinicians suggestions to help meet the access, to help improve the access that their patients have to them and to decrease some of the open slots. So one of the things I know about behavioral health providers, and also being a behavioral health provider, is that double scheduling or double booking, as we affectionately like to say, is probably universally hated by clinicians of all disciplines and often really difficult to gauge and problematic. So one of the things that has come up as a solution is creating a shadow schedule. So essentially, when you go through and you look at your open slots, you look at when they are, what times of day, and you really do a process called hotspotting, which is getting really good at knowing when you're going to have open slots in your schedule. And then what I do is create a shadow schedule. I like to call it Dr. Seuss because I like Dr. Seuss. And when somebody calls and says, I would like an appointment to see a behavioral health provider, then we put them on the Dr. Seuss schedule at a time when we're really pretty sure that we're going to have an opening. And then as patients cancel or don't come in, or as things get moved around on the schedule, then we move that patient into an open slot for one of the providers. And so this is not something that really works well if you have one provider in a primary care clinic, you have one behavioral health provider. There's some other scheduling things that you can do. But if you have 2 or 3 behavioral health providers, then you actually get really, really good at doing hotspotting and figuring out when you can open slots on your shadow schedule and then move people in. So I know if I'm a clinician, if I have a cancellation or a no-show, or an opening on my schedule, that it is possible that someone will get slid in from the shadow schedule into my schedule. And so that's a little bit about how the shadow schedule looks and what that whole philosophy or what that whole idea of shadow scheduling is. And then again, thinking about your average collection, how much collection a month. So we had a practice, actually, I think they were in Montana, now that I'm thinking about it, and the behavioral health director figured out how much she would need every month to cover her fringe, her salary, her fringe and overhead, and sort of the expenses of her department, and then really looked at what the total revenue collection was for that month, and she had a certain dollar amount that she was shooting for, and she was able to actually meet it and exceed it. But it helped her to sort of know, and what it did was it helped her as she made changes. So if she said, you know, I need to make $17,000 a month in revenue, as an example, and she changed the schedule or she made a change in her system and she saw that it increased revenue or changed how much she was able to bring in, then that helped her to really gauge some of the interventions and things that she was doing in her system to help the sustainability and improve the revenue and make those services self-sustaining. So certainly that's something to really think about and know what your average collection is a month and what you might need. One of the things about that, though, is remember that it does take some time. You know, in a perfect world, we would send a bill to payers and they would send us a check or an electronic payment. However, in the world we live in, which is not always perfect, it takes some time for payers to pay us. We might get paid very quickly from our state Medicaid, but it may take a month or better for some of the other payers. So remember that you might have to look at that information back a month or two in order for it to be really accurate. So thinking about starting, because one of the things that we want to try to do after you leave this webinar and go back into your practices and into your services is to think about sort of what do I do next, right? I need to make this sustainability. I need to think about putting a dashboard together. I need to think about where I'm going to go from here. And so I think that it is really helpful to start to think about what we like to say is, chunk it down. We always tell our patients, partialize it down, make it small, something small and manageable. So this is an example where we need to follow our own advice. Pick something, one area, really break it down and do a deep dive into that particular area. And, I have a behavioral health director in Washington who initially was not as interested in the sustainability part of her services and actually came to love it when she really understood it and really realized how she was able to grow her services. But one of the things that she said was sort of breaking it down and doing a deep dive really helped her to understand some things that she had never had the opportunity to learn before. like about denials and what the denial codes mean, or credentialing and what it really means to be credentialed, and to be a PAR provider, to look at contracts. And so by sort of taking each area of the business at a time and really doing a deep dive, learning at what information she needed to know and getting an understanding of it, really helped her to not only develop a sustainability plan, but to really make programmatic decisions as well. So think about, picking an area to work on. So a lot of times people say, well, I don't really have access to the billing and some of the denials. I don't really get that information. I'm not sure who I would get it from. So I think that's something that you should work on so that you can get it and start to put this plan together. So then maybe think about another area of work, like maybe you're going to look at the open slots and start to optimize scheduling and see what a difference that makes as you start to do some work there. Or think about the largest fire. Are you, not getting providers credentialed and losing a lot of billing? Do you have a lot of patients that aren't keeping appointments? Are you getting a lot of denials? Wherever your sort of largest fire is or thing that you think is having the most impact, maybe that's a place to start doing some of these services or doing your deep dive into sustainability. And so that's the end of what we were going to talk about today, sort of as a structured webinar. I know that I've been trying to go through and answer some of the questions as they've come up. So feel free to type questions in now, and I'd be glad to answer them or speak to them or get any information back to you that you might need. Again, sometimes this can be a little overwhelming. You just have to start to break it down. I can tell you that it is absolutely possible, to have sustainable services and that you can figure out. Sometimes it's not going to be all from one place. You're going to have to piecemeal it together, thinking about workflows and scheduling and thinking about all of your payers. So it's really good to know all of the places that you're going to get money from and try to understand how you can optimize those pieces. So I don't know, Joan, if you had anything that you wanted to add or any last thoughts before we end for today?
Yes, I did. First of all, I want to thank you, Virna, once again for certainly was a deep dive. And for everyone who was on the webinar, what I would say is when you get the survey to follow today, if you have questions left, which I'm sure you do, I don't know how you could not have questions, but if you have questions, if you have comments, definitely write those down, and Virna and Jeff and I will be putting our heads together to think about sort of whether we want to schedule a time for an open discussion time. In addition to that, we have the third in our series of webinars, and I should have looked at this before I got on the phone, on April 16th, I think, is the final webinar. Again, same time, 2 o'clock Mountain Time. The final webinar on financing integrated behavioral health, at least the final one for this series. So give us your questions. Let us know what you thought. And Virna, thank you again for your time. Have a great afternoon, everyone.
Thank you.